Thank you. Sorry.
You're welcome. So guys, as recording was not on, so I'll go back. So these are the objectives for today's session. Now you're looking at a side view of somebody and you're looking at the muscles. So what are these muscles which has been visible to you? You can see here. This muscle is what? The pectoralis major, and then this is the latissimus dorsi, and in between you're looking at the serratus anterior. Why I'm calling this muscle as serratus anterior? You can see very clearly the serrations. Can you see these serrations? That's the medial wall, lateral wall of my rib cage. Laterally you're looking at. And then arm is where? Arm is abducted. So this place, what is that place? Right inside. This is where I'm indicating. That place is called axilla. Axilla is a potential space. If my hand is by the side, axilla is there. If I'm abducted, axilla is gone. This axilla is a pyramid-shaped structure which connects the root of my neck to my upper limb. And through this, so many structures passes. Either they are coming from the inside of my thoracic cavity or they are coming from the neck. And they have to travel. This is the gateway. This is the pathway which transmits. And this image is showing you from a side view. Let's bring another. And there you can see that these all are fresh cadaveric pictures. And you're looking at the pectoralis major in front, which is bright red in color, and then on the back you're looking at another one. So now this is further dissection and which demonstrate what? What are the structures which we're supposed to learn within the axilla. So you can see a bunch of nerves, arteries, veins which are there. In short terms, I call them as neurovascular bundle. And plus I have lymph nodes and fats. Are we clear so far? Let's proceed. So now this is someone like you and me, and you're looking at some area is being highlighted here. Look at it. Can you see there's a fold made? You can feel your own. You can feel in your own body. Feel it. Put your hand in a pinch. Why don't you do it? Just feel it. You're holding a fold. And that is my anterior boundary. And then on the back, you hold a fold. That is the posterior wall. So we have an anterior wall and a posterior wall. You can see it here. What you are holding? You're holding your pectoralis major. Minor was inside. So this is what you're holding. Then this is the passage. This is a pathway which transmits neurovascular bundle. And the destiny is what? It has to reach to the upper limb for control, for supplies. Looking further, another view with association with the bones. And then you can see that the vessels and the nerves which are going through that. Are we clear so far? Now, this is a section, a transversely going section from a human shoulder. And you are looking at, I don't understand anything in this one, so I need to look in this image. That highlighted area, pinkish area is indicating what? The axilla. And you are looking at its walls, anterior wall, posterior wall, and then other things which will coming up. And then inside that, you are looking at the neurovascular bundle. Going further, same what I was talking. Now, let's start making this axilla. So, this is the base or the floor. Who makes it? Skin of my armpit, where we have these hairs, the secondary, the hair grows in your axilla. So that skin is forming the base of my axilla. And that is the base of this. Then you're looking at, and on the top you can see that there's a small window, and that is the neck or the top part or the apex part of the axilla. So now this is a wall. As I told you, this is like a pyramid. Those of you who have not seen it pyramid, when there is good time, go Egypt, visit, and there you can see in Egypt these pyramids are there. So this is which wall it should be, guys? Medial wall, perfect. So what structure should be there? You can see it. Can't you see ribs? And then we all know to these ribs what I have attached. Someone who's serrated, serratus anterior. So that is ribs and upper ribs. If you forget which number of ribs, it's okay. You just say that upper ribs and serratus anterior muscle, which is attached to them. So those are the things which are making the medial wall. I hope everybody understands. So this blue thing should be what? Lateral wall. And there are so many structures. So who's there? My humerus. And those structures which are attached to that, they are making the lateral wall. Then we have this green thing. What is that? Anterior or posterior? Posterior wall. So I have so many muscles, subscapularis, latissimus dorsi, teres major. They all contribute in that in some extent. So this is my posterior wall. And then this is my anterior wall. And who makes my anterior wall? We all know that. Pec major, pec minor, and subclavius little bit, tiny tot. So these are the ingredients of my, so broadly speaking, my axilla has an anterior wall and a posterior wall, a lateral wall and a medial wall, an apex and a base. Are we clear? Okay, now let's see what happens. So let's cut this pyramid. So let's section it. This is the apex which is going towards the neck, towards my rib cage. These arrows, we talk about it. And then all what is coming from my neck, all what is coming from my rib cage has to go to my upper limb to control. Guys, this is on both the sides, both right and left. Don't live with this concept that only we saw on one side. No, it's on both the sides. So now, for better understanding, I'm cutting this pyramid transversely. When I cut it from point A to A, what appears for me? I get a section like that. And now you can see yourself, where is anterior, where is posterior, where is lateral, and where is medial. And you're looking at what? Anteriorly, let's label it. This is sternum. This is what? My humerus bone, showing its two lips. This is my scapulae. And these are my ribs. It could be any number. Let's not get in this detail, 1 or 2 or 3 or 4 or 5. Just say ribs, period. And then this is the groove on the upper end of the humerus you must have seen in the labs. We call it intertubercular sulcus, bicipital groove, so many names for that. We are good with that. So now let's begin. Anteriorly, what we were talking about, pectoralis major. So let's put it here. Can you see that? Pectoralis major. And then pectoralis minor. They are present anteriorly. They are making anterior wall. And then medially, ribs and serratus anterior. Are we good? Then posteriorly, subscapularis, teres major, latissimus dorsi, so many of them are there. Are we fine? Because when you look at different levels, you'll see different structures. So you can see those contributions. How all these muscles which I have named, on top of the list, subscapularis. Then you're looking at what? Teres major. Then you're looking at latissimus dorsi, and you've seen, you're looking at all those three tendons. And what all these three structures, they are contributing in making my posterior wall of the axilla. Laterally, we have the bicipital groove or intertubercular sulcus, and it contains tendon of what? Long hair of the biceps. Are we clear? Some other further tendons. Short head is also little away. Some other muscles, but they are not exactly in the lateral wall. So this you need to be good at it. Axilla, where it is located. Who makes anterior wall? Who makes posterior wall? Who makes lateral wall? Who makes medial wall? Where the apex has to be, where the base has to be. Now, what does this axilla contain? Its contents. So let's fill it. This red tubular structure should be an artery. Axilla, axillary artery. If it was something else, if it was femoral region, femoral artery was the name. So axillary artery. And then which vein this should be? Vein. I know it's a vein. I am asking you which vein it should be. You're saying vein. Wow. I love your answer. So this must be my axillary vein. And then I have some nerves which are widely scattered all around my artery. So they are surrounding on three sides. These nerves are present on three sides of this artery. So they are those nerves which are going to supply my upper limb. So they are part of my brachial plexus. So the nerves which are coming from the brachial plexus. What the hell is this brachial plexus? We'll be talking about that. Now everything is enclosed in one sheet so that it should not be running away from each other. So everything is enclosed in this green color structure that we call it as axillary sheath, which keeps everything in its position. It's not happening, you're moving, you're dancing, you're jumping, and these structures are going or running away from one place to other place. Everything should be at his specific place. So this axillary sheath does that job. Are we good so far? So if somebody asks you who makes the boundaries of axilla, you should say that anterior wall, who makes it, posterior wall, who makes it, medial wall, who makes it, lateral wall, who makes it. Then where the apex should be, where the base should be. And what are the structures? Simple. Vein, artery, nerve. Which vein? Axillary vein. Which artery? Axillary artery. And which nerves? Parts of the brachial plexus. Nobody is asking you exactly what. Then what I have further. So then these nerves are giving their branches. If you don't know their name right now, it's okay. You're looking at the lateral and medial pectoral nerves, and they are showing you supplying these two muscles. You may agree. My book says only minor, and my inbox is full of these questions. But I will show you even in the dissection labs, both of them are working. Then this whole space is filled by a packing. Can you see that the color has been changed? Look at it, it was white. Now it has been changed. What's that? That's the axillary fat. And the job of this fat is the structure should not be moving freely. They should be placed, they should be embedded. Let's say you purchase any electronic gadget. It comes with packings. So what's the benefit of this packing? That it should not be wiggly within the box. Then we have plenty of these ovoid structures, and these are really important clinically. These are the lymph nodes. Breast cancer is one of the killer of women. And these lymph nodes are really determinant factors in deciding that what stage of the disease is. We'll learn that shortly, not in this block, but in our upcoming blocks, we'll be talking about these things. Are we good so far? So axillary lymph nodes. Okay, so now I'm done with the axilla part. So let's begin with the spinal nerve. People have talked about spinal nerve. My colleagues have discussed this at various times. In foundation, you had 2 lectures. Ayman has explained in one of our structure of the lab session. He was quite elaborative in that part. But now, each block you learn something from the nervous system, organization. So spinal nerve, I hope everybody should know. But first of all, what you're looking at, the skull and the vertebrae, the whole vertebral column. Look, you can see that there are different colors to it. So the upper segment are the cervical vertebrae. They are how many? They are 7 in number. Then the thoracic segment, they are 12. Then the lumbar, then the sacral, and last are the coccygeals. So this much vertebrae are there who makes my spine. When I use the term spine, means vertebral column. We need to understand this concept. Going further, we can see in our body how the spinal cord, what is the spinal cord? It is the continuation of my brain. It travels through these vertebrae. Each vertebrae is there, what for? To transmit, to keep this spinal cord. Spinal cord is the continuation of the brain. And this spinal cord, from this we take these nerves. And these nerves are responsible. This is the main power supply unit of my and your body. If these nerves are cut, we cannot bring any movement. We cannot have any action. So we need to understand. So now, to elaborate it further, you can see that how many spinal nerves are in the upper segment, how many are in the middle segment, how many are in the lower 2 segments. 8, 12, and vice versa. Okay. Now, let's take one of them. From all of these, from the top till bottom, I'm taking one example. This is a section which is going through my spinal cord. Let's level it. So now, this is the white matter because it looks white to you. And that's the gray matter. Are we good? This is the organization. So now, this anterior horn is in a circle. It is for motor activity. So ventral rami or ventral horn or anterior horn. and there is a nucleus here. From this, I get motor fibers. So my each spinal nerve has motor, sensory, and sympathetic. Why I need a motor? For movement, for action. Why I need a sensory? To getting back the infos. And why I need sympathetic? For some smooth muscle control. Are we good so far? Gentlemen, if you are here for sleeping, hello, can you tap him? If you are here for sleeping, go and have some coffee and chill. I need people who are active. So this is my motor component of my spinal nerve. Then what happens? Because you know what happens? If you're teaching and you can see people are sleeping in front of you, then you feel like sleeping yourself. And the whole class will enjoy. So if you're sleepy, get some coffee and sit down. I don't mind. I know it's a difficult time. So guys, now I'm highlighting this big swollen part, which is in my posterior roots. And that is what? Where I have dorsal root ganglion. Who lives there? That's a sensory nucleus, sensory neuron. And this is being connected backwards with my spinal cord. And through the spinal cord, it's connected with my brain. Then it's coming forward. So my sensory component is coming forward, my motor component is coming forward. Then I have what? The dorsal root. So now they are making something which is spinal nerve. So a motor component and a sensory component. Can you understand motor and sensory? If I see something coming to me, this is sensory input. Either I can see it, or I can smell it, I can feel it. That's sensation. It goes to my brain. Then my brain integrated. What the hell is this? If let's say an arrow is coming to you. So what is the order? Brain says, brain synthesizes this information within no time. Eye is your camera. It captured something sharp coming to you. It can kill you. A bullet, I don't know, you can negotiate a bullet, but arrow, I think you can. Don't try with a bullet. So the order comes, move. So suddenly you move. If you move, how you move? The motor fibers has been sent a order. These muscles, these joints should move. So when they act, you achieve a movement. And this is how your motor and sensory are working together. Sympathetics, they are controlling smooth muscle. Where you find smooth muscle? In the blood vessel walls, within the glands, sweat glands, and so many other areas. So you need to have them. So now, this is the nucleus. Can you see this green thing? This green thing is a source of my sympathetic. I will be having another session just before to your midterm exam. There I'll be talking about autonomics, organization of your autonomic system. So this green thing is a source for my sympathetic. This is my sympathetic neuron. And there we can have the sympathetic input. So each spinal nerve has motor, sensory, and sympathetic. So this formula goes with all 31 pairs of spinal nerves. We have 31 pairs of spinal nerve from top till bottom. We have these 31 pairs of spinal nerves, and these components are there in each of the. I'll take your question at the end, not now. Now, what is plexus and why we need a plexus? First of all, let me show you what is called plexus. So I have taken now, before we were looking at one section. Now we are looking at two sections, two nerves. And what is happening? The same principle is happening. I have taken the example of C4 and C5. Plexus means the place where so many spinal nerves. This number is not fixed. Could be 2, could be 5, could be 10. They merge together. For what? Sharing is caring. If one is damaged, other one will take care of the job. Maybe not that good, but to a certain extent of help. Make sense? So that's called a plexus. And the plexus, where we have plexus formation in our body, and those places, my spinal cord goes enlarged. And there we have two swellings in the spinal cord. One in the upper segment, one in the lower segment. Upper segment, I derive two plexuses, cervical plexus and brachial plexus. From the lower segment, I derived two plexuses, lumbar and sacral plexuses, and they are the main plexuses which control my limbs and the neck structures, so the muscles. So now let's make a plexus. One example, we have taken section of spinal cord at 4th and 5th cervical vertebral level. So we chop the spinal cord at that level. So let's bring them together. You all know, you're all good with ventral and dorsal roots. Now, we all talk about that shortly. So basically what happens? So now you can see that from these two, the motor and sensory fibers, they blend together and they make one spine, plexus. And then this plexus is further divides and divides and divides. We'll be talking about that. Are we clear? So this is how we are blending two spinal nerves. Each spinal nerve has motor, each spinal nerve has sensory, each spinal nerve has sympathetic. So now this all has been blended, then we take branches again after this. Are we good? Now, let's talk about brachial plexus. Let's draw it. So for that reason, this is how it looked like. Can you figure out what the hell is this? It's difficult. I don't know. I'm lost. Let's make it organized. So I draw it. I have made this column for you. And then these lines, the vertical lines are indicating certain places, certain levels. So my first thing is the root. If you take a plant, it begins from a root. Then the root becomes a trunk, and then the trunk gives branches. Then they divide and blah blah things. Are we good? So this is the roots. So where the roots, and then roots will become trunks. Trunks will divide. So we call them divisions. And divisions will become cords. And from the cords, I have the nerves or the branches. So please focus on this. If you learn this table, nobody can challenge you in brachial plexus. And you have to do this practice. If you don't do that, if you leave it for tomorrow, I have my doubts. So now, where the roots are located, prevertebral region, area just next to my vertebral bodies, where the vertebrae are, that's the area for the roots. If I have to find the roots, I should go that deep. So then what we are using from each spinal nerve, we learned that there was a ventral root and there was a dorsal root. For making a plexus, we only use ventral rami. We don't use dorsal rami. So now this is one spinal nerve, which is shown with this yellow dot. This is my C5. Who this should be? C6, C7, C8, and T1. Perfect. So these are the roots who contribute in making one plexus, and that is called brachial plexus. So these roots are where, if I have to go on a cadaver, and if I have to look for these roots, I should be going in the prevertebral region. These all roots will be visible to me, like you have seen in the previous picture. So now, from these roots, what happens? 4 and 5, or 5 and 6, they become friends. They join hand. 7 has nobody. And C8 and T1, they become friends. Just follow that. 5 and 6 join. 8 and 1 join. But C7 has nobody. So now, where I find the trunks? Interscleni. What is this interscleni thing? Scleni is a muscle. These are the muscles which are located in my neck. We have anterior sclenii, middle sclenii, posterior sclenii. These are the muscles which are present in my neck. You need not to learn them today. Don't get stressed. So if I have to look at the trunks, they will be found between these muscles. So now my upper two, they give me one trunk. The one, and I call it superior trunk. The one who's alone. Nobody is sharing, nobody is friend, but it's a middle trunk. And those in the bottom, they give me inferior trunk. Are we good? Now, my each trunk will divide into Anterior, posterior, anterior, posterior, anterior, posterior. One is for the front, one is for the back. One is for the front, one is for the back. All this is happening from where? From the ventral rami. Dorsal rami is not contributing. Go to this root level. So now my trunks will divide. Superior trunk, and this is, I'm showing you the spleniae muscle. Okay. Before going further, I have some branches which are coming from the roots. This brachial plexus gives some branches which are emerging from the roots. So the first one from C5, and that is my dorsal scapular nerve. And that is innervating what? He's controlling what? My rhomboids. Guys, you were asking me, do we need to memorize C5 and C6 and C7 and C8 and T1? And I was telling you, after this lecture, it will be clear. So you need to remember these, but not for every nerve, for some big major nerves. If you try to go for the small things, it's your choice. But you are not recommended to learn for the small, tiny things. Learn for big things, for the main things. So this is my dorsal scapular nerve, and you know it. Where does it supply? The rhomboids and the levator scapulae muscle. This is the nerve. If this nerve is cut, those muscles will not function. They may function because there are some more contributions, small contributions are coming, but the major effect is gone. The major work is lost. Then I have from C5, C6, C7, somebody who's very important. This was the one who was controlling my one muscle, serratus anterior, long thoracic nerve. And if this nerve is gone, I cannot get, I will have winging of the scapulae. Winging of the scapulae is because of long thoracic nerve, and the muscle is serratus anterior. That's it. No one else. No one else. Please be clear about it. You open, I have 400-500 books of anatomy. Maybe one or two differ a little bit, but this is the main major thing. Please stay focused. There is one classical anatomy, one is clinical anatomy. We are here learning clinical anatomy. We are not talking about classical anatomy. Don't waste your time. Stay focused to the point. Somebody was saying how I manage time. If you go in classical anatomy, you may need 6 months to finish this brachial plexus only. That much details are there. You want, I can share with you. But stay focused with the clinical aspects. Don't waste your time. So we have learned what? C5, C6 and C7 roots. From there, I get the long thoracic nerve. And this long thoracic nerve is the sole nerve supply of my serratus anterior muscle. And that is responsible for increasing the reach of my upper limb. It brings the protection of my scapula. And it is the one, if this nerve is damaged, my medial border of the scapula is not fixed with the body. That's why it's become apparent. It becomes visible. Under normal condition, you cannot see the winging. But when somebody apply force, this becomes more visible, more prominent. If someone has winging of scapula, it's not a big deal. People survive. I gave you an example. We have 2-3 kids at Al Faisal who have this winging of scapula. It's okay. You can live a life, normal life, no issue. So this is the long thoracic nerve which was coming from the roots. Then we have in the trunks, we have what? What is that nerve? Suprascapular nerve, and you know it. Where does it supply? Supra and infraspinatus. And from where it was coming from the trunks. Then I told you, my trunks, they divide into anterior and posterior. Anterior and posterior. So the anterior division from my superior trunk. This is the anterior division, and that's the posterior division. I'll give yellow to my superior and to my anterior and blue to my posterior. So now anterior from the middle. So all the posterior trunks, all the trunks, which trunks? Superior, middle and inferior. Their posterior divisions, they join to form one. And their anterior divisions of what? Superior and middle, now they share. And then the lower one has been alone, previously it was sharing, but now it's alone, no friend. So now the anterior divisions of my superior and middle trunks, they join to give me a cord. So it has been pop out here. There are no branches from the divisions. We have branches from the roots, we have branches from the trunks, but we don't have any branch from the division. So this upper two anterior division, they make one cord. And that cord is what? Lateral cord. Why is lateral? Because it's lateral to somebody. And then this will become my medial cord. Why it is medial? Because it's medial to somebody. And this will become my posterior cord. Why it is posterior? Because it's in relation. It's on back of someone. Who's this someone? That is my axillary artery. You remember in the axilla when I was showing you axillary artery, I have shown you three nerves shown in different direction. So on the basis of that, the one who's lateral to my artery is the lateral cord. One who's medial to the artery is the medial cord. And one who's posterior to is called the posterior cord. Are we clear? So now, from the cords, we are getting branches. Who's that? Lateral pectoral nerve. We all know it supplies pec major and minor. And then from the medial cord, go opposite. Medial pectoral nerve. Guys, this is not a rocket science. Just if there is a lateral, bring medial. If this is superior, bring inferior. If there is major, bring minor. Are we good? So you have lateral and medial pectoral nerves. Then my medial cord gives a branch which goes forward. So many. So these are medial cutaneous branches. The word cutaneous means sensory component. When the term is used, sensory, cutaneous means sensory, the one who goes just for sensations. So from my medial cord, you can see that there are two cutaneous branches which are going forward. And what are these? These are medial cutaneous nerve of the arm and forearm. So one is bringing sensation from my arm, and other one is bringing sensations from my forearm. They are cutaneous nerves. So medial cutaneous nerves which are coming from the medial cord. And now from my posterior cord, you're looking at one branch. Who is this number one? Upper subscapular nerve. We talk about it. This upper subscapular nerve was supplying where? Perfect. Number two. Perfect. You guys are smart. So you are looking at the upper subscapular and lower subscapular nerve. Now if somebody asks you, you know it. They are coming from my posterior cord. Then this is the big one. Number three. That is thoracodorsal nerve. Which big muscle? Latissimus dorsi is a huge muscle. Now, the branches. Now my lateral cord continues. Medial cord continues. And posterior cord also continues. So lateral cord, medial cord continues as what? As ulnar nerve. Ulnar nerve runs on the ulnar side of my body, on the medial side of my body. If I stand in an anatomical position towards my pinky, anything which is towards my pinky, any muscle, anything, their nerve supplies the ulnar nerve. It goes behind a bone here. You must have noticed that if accidentally you hit on the surface of a table, you have an electric type of current which is occurring. Primarily, you can roll over this ulnar nerve. And this ulnar nerve is responsible for very fine tuning movements. You are artist. You can draw. You can do some. You can play some instruments. My hand is primarily controlled by the ulnar nerve. All the fine movements, different crafts, from surgery to some other special characters. Everybody cannot be. You can do some very fine work with different instruments. It's all because of your hand. And there are small muscles in your hand. Those are intrinsics. And primarily, their supply is from the ulnar nerve. So this is the ulnar nerve, which is the continuation of my medial cord. And then my posterior cord continues as the radial nerve. And then it gives one very important branch, the axillary nerve. Axillary nerve goes under the deltoid, around the neck of the humerus. And it supplies deltoid and Major? Who says major? Teres minor. Be careful with that. So this nerve supplies there. Somebody was asking me this morning, what is the site for intramuscular injection? Guys, I have explained about it. I'm saying for you again. Acromion process, 4 centimeter blow, stay in the midline. Don't go backwards. Don't go forward. Stay in the midline. This is the place where you can give the injection. If you give above, what's wrong? You may enter into the cutaneous branch of the axillary nerve. If you damage, and there are chances you might damage, you might cause a damage to this cutaneous branch of the axillary nerve, and that will result loss of sensation onto the outer aspect on your deltoid under the skin. So you will not perceive any sensations there. So now from my posterior cord, I have a branch which is going backwards. That's my axillary nerve. Axillary nerve, yes. This is a nerve, you should remember. What is this C5, C6 value? For median nerve, yes, you should be knowing. For radial nerve, yes, you should be knowing. For ulnar nerve, yes, you should be knowing. But not for previous things. Long thoracic, yes, C5, C6, C7 roots. But not for upper subscapular, lower subscapular and other things. So now I hope you can manage how and what I'm trying to say. Are we clear so far? So now the story is not complete. From the lateral cord and from the medial cord, I take one contribution from the lateral cord, one contribution from the medial cord. Before saying that, my lateral cord continues as musculocutaneous nerve. You remember that? My lateral cord continues as musculocutaneous nerve. This musculocutaneous nerve is the nerve for flexor muscles of my arm. It supplies biceps. It goes through the coracobrachialis. It supplies coracobrachialis, it supplies biceps, and it supplies brachialis. These three muscles. After supplying that, then it continues as a cutaneous branch, lateral cutaneous branch of the forearm. So, my medial, I have medial cutaneous branch for my arm and forearm, they were coming from the medial cord. I have lateral cutaneous branch for my arm and forearm, they are coming from where? From the lateral cord. So, lateral cord, its fate is musculocutaneous nerve. So, lateral cutaneous nerve, it's the musculocutaneous nerve, it supplies up till the elbow, beyond its sensory. My ulnar, it don't have any contribution in the arm, but it has all the contribution, very little contribution in the forearm, but the main contribution in the hand. And my posterior one, it gives the axillary which supplies area under the deltoid, and then it also goes to the back. So before saying that, now I have derived two contribution. From where? From the lateral cord and from the medial cord. So these two roots, they join to give me a big nerve that is called as median nerve. And this median nerve is primarily supplying the flexors of my forearm and few muscles in my hand. Guys, these are the very, very important concepts which has to be very clear in your minds. If you are in doubts, trust me, if you look back in the MSK, if you are not good with the actions, if you're not good with the nerve supply, but we'll not ask you name the nerve supplying flexors. We are not asking you name the nerve supplying extensors. We will put other way, like you have seen some of the examples during your TBL today. This happened, that happened. If this nerve is damaged, which muscles are not working? If this action is not able to brought, which nerve is being damaged? So you have to connect these functions with the name of muscles to a joint and to a specific nerve. And if you fail to do so, then I feel sorry for you. So you have to be good with that. And be reminded, today, my peer tutors, and tomorrow, all, the boys is having your session tomorrow. When you'll go to the lab, there are more than 2-3 stations where you should see these nerves. Don't put your time for the roots, like identifying where is a long thoracic, you may not find it. But you are expected to find out where is the musculocutaneous nerve, where is the ulnar nerve, where is the median nerve. If you are able to find that, enough. At least this is the minimal in the first go. You are expected to know that. So from my posterior cord, we talk about it. and now my lateral cord give a root, and medial cord give a root, and they are becoming the median nerve. And this median nerve is primarily controlling the flexor muscles of my forearm, the huge muscles, and then few muscles in my hand. Primarily, the muscles in my hand have been controlled by the ulnar nerve. I have so many, and these are the intrinsics. Dakhli. Are we clear? Okay, guys. So now this is the one. Lateral to it, medial to it, posterior to it. So this is my axillary artery. Okay. So I'm sure. So guys, this exercise which we have done right now, you are expected to draw, redraw, draw, redraw, and then you'll become master to it. It's not a rocket science. So now let's see on a. I'm showing you the scalenii muscles. And you can see that these roots. We know that roots become, so these are my anterior and middle, in between these roots are emerging. So if I have a problem between the roots, these muscles, these nerves can be in danger. This is a nerve which we are not talking here, we'll be talking in CVP block in a big detail. So now from here, these branches which we have talked about, they are coming up. And they are giving lateral cord, medial cord, and posterior cord. Can you see that? And I'm driving what? Musculocutaneous nerve, it's laterally, coming from the lateral cord. Ulnar nerve coming from the medial cord. And radial nerve coming from the posterior cord. So these three. When you go to the lab, look for this M formation. This M. Ask somebody. In each group, you'll find one peer tutor. Ask him or her. Show us where is that M. You can take the help of this person. He can help you and he can guide you. Have good utilization from this person. So now these things are there. There are various branches which we have talked about it. These are on the real situation. Are we good so far? So these are just the labels of the same what we have talked about. So I'm just making roots. You can see the level of the roots. You can see the trunks. Can you see these number 1, 2, and 3, 4? Trunks, divisions, cords, and then the main branches. So we understand now, we should understand now, if the problem is at the roots, what will happen? If problem is at the cords, what will happen? If problem is at divisions, what will happen? If problem is at branches, what will happen? So these nerves can be damaged for any reason. There are so many reasons. Trauma, some anomalies, other issues. So these nerves, if they are involved, then we have to negotiate, we have to handle these people. Now, what is this? Somebody is dancing? Does it look normal to you? No. Does this guy look normal to you? How about this one? Look, compare his two forearms. What is that? This is the area where we are doing a dissection, a surgery on someone's brachial plexus. You can see the numbers 2, 3 and all that. So this is the root of the neck where this work is on, and these people have injuries which have occurred to their different parts of the brachial plexus, and this is how they will present to you. This is how these people will present to you. And then for so many of them, if they present early, you can do some surgery. If they present late, then you can try. Make sense? So if you see somebody have some deformity, advise them, go and see a trained doctor. Don't wait that when this child will grow big, everything will go fine. Nothing will go fine. You have to eat food, you should carry it towards your mouth. Allah has given you a hand to eat food. Food will not jump in your mouth. So you have to make some effort. So now, let's talk about injuries to the brachial plexus. So we can classify it. So the injuries, upper part of the plexus at root levels and the lower part of the plexus. So these are the main further down. Now, this is a big detailing about that. So let's see what is happening. during a childbirth. Most of us, those who are not born because of C-sections, because of cesarean, this is how we were all born. There's nothing to shy in this. This our head come first. So if we were troublemaker, or if there was something wrong, if my parents were not really cautious, so now what happens? When the process of delivery is on, the nurse who is assisting this delivery might have caused stretch. You can see the result of stretch. And that is what tearing my brachial plexus, upper part of my plexus. Now this child, when he is born, one hand will be like that towards the body and rotated. That's the simplest thing. I know someone, they went to US for a childbirth. Oh, the child will have a nationality and all that. And they were visiting. They were friends of friends. One of their child who was newborn, hand was like that. I asked them on purpose. I knew it, what it is. I just asked on purpose, what is it? What it is? What happened to your child? No, it was like that from the birth. And the doctor told us. I'm talking US year back. I'm not talking somewhere in Africa. Doctor said it will go fine. I said, excuse me. They were from Riyadh. I said, excuse me, because their flight was booked. I said, when you go to Riyadh, go and see so and so and so, because this is a serious issue. If you don't intervene, your child will stay like that. One hand will not move, and it will be deformity, and there something went wrong during the process of childbirth. It was the job of your doctor to communicate to you. Fine if they haven't, but you should be cautious. You should look for, don't expect everything will go fine. You can see that the child is moving one hand freely and the other hand is rotated and is fixed towards the body because certain things has been lost. And you can speculate. We'll be talking a little bit more here. So the similar situation, we call it abductional palsy. What's that? Somebody falls like that. The angle increases between the neck. Let's say how you fall when you're falling from the back of a horse. If your horse is notorious, might throw you down and you might land up on your neck and shoulder. So in between you get a stretch. As a result of that, this is root of your neck. So your brachial plexus. So the upper roots, they might sustain some stretch, some trauma. And this is the result. Have you seen it before in the previous child? This is classic abductional palsy. And what it says, waiter tip hand. Old days, not nowadays, waiter will stand in front of you if you don't pay him tip. But old days, they were very smart and they were just moving around, hand goes like that. So you can just tip in silent. But nowadays, you have to give. Even so many restaurants, they put in the bill this much service charges. So, but this, what is in this red box written? I need somebody to write it for me, to read it for me. Can somebody from the hall read it loud? Read it.
This injury usually occurs when someone is thrown off their horse.
Can you remove your mask and speak loud?
This injury usually occurs when someone is thrown off their horse or motorcycle and lands on the ground on the side of their legs. The trauma involves forcible separation of the head from the shoulder, increasing the angle between neck and the shoulder, stretching the upper parts of the brachial plexus, namely C5 and C6. This results in loss of shoulder abduction.
So loss of shoulder abduction. So shoulder will stay what? Adducted. So you cannot abduct it. 1, 2.
And elbow flexion.
Elbow flexion because extensors are not working. So elbow will stay flexed. Yeah.
The resulting deformity in the upper limb is referred to as the waiter's tip. Pronated.
Because you cannot bring supination, so it remains pronated. It remains, this is the posture. Yes, continue.
There may also be loss of sensation over the lateral aspect of the shoulder, arm, and lateral forearm due to involvement of the axillary nerve C5, C6 and musculocutaneous nerve C5, C6, C7.
Thank you very much. So guys, this is important what he was reading for you. You all are expected, we might ask you this reason, why the arm is abducted, why is not adducted, or why is adducted vice versa, why it is not supinated. Then you have to say that musculocutaneous is gone, this is gone, that is gone, because deltoid is not working. So when someone's deltoid is not working, what will be lost? Major abduction will be lost. Supraspinatus give you a little bit, but the major abduction will be lost. So hand will be close to your side. So you have to think critically about these. And that's really, really important. And I can assure you, you'll find questions on that. I'm not hiding. I'm open and straightforward. Come, get ready with this. Same thing. Injury upper part. This is how the picture of the child will be. Same. Same. Now, the injury to the lower plexus. You're falling from a height. You hold a tree. Oh, yes, I'm survived. Yes, you survived. But the stretch, where you'll find a stretch which cause in your axilla, will result injury to your lower part of the plexus. And where is my lower part of the plexus? Here you go. Klumpkes. Your hand will go like that. This is classic Klumpke. Claw hand. There are so many type of claws. Hand of benediction, ulnar claw, this claw, that claw. And the main reason is the lower part of your plexus has been endangered, has been damaged. So this is the same description, you should be knowing it. And along with that, we have certain other associated features. Lower part, look at the face of this child. Look at the eyes. Look at both the sides. Horner syndrome is there. You are expected to be good with these, what I was discussing with you, what I'm showing with you. Now, what are you looking at in this image? Someone arm is red? But why is red? Is it really red? Someone has a severe pain. Someone in severe pain. He present to your clinic. You evaluate him. Brachial plexus. Injury where? At the root levels. If someone has an injury at the root levels, he may present in the clinic like that. You do an X-ray of his neck. Look at the vertebrae. And we all talk about the brachial plexus. The roots are in the prevertebral region. You can see that the area which has been indicated by the red arrow. That area. Maybe the disc space has been decreased. So this nerve has been compressed. How I can see that in this given X-ray? You can see that. These yellow and blue and red dots. So there is something wrong. And that will result in a very specific condition, cervical spondylosis. Severe pain, loss of sensation, and all that. Person will not feel paresthesia, like my hand is not there. Anesthesia, absence. So basically these nerve roots has been compressed. And this is a classic picture called cervical spondylosis. And you must have seen people wearing those collars. And they were given certain physios and all that. People will heal. But the problem is at the roots of the brachial plexus. So if the injury is occurring at the roots, this is the condition. Are we good? Guys, this is what you need to be good at. Now, this place, what is happening? Spleniae muscle. If someone's spleniae muscle become very strong, very powerful, so they are compressing what? After roots comes what? Trunks. So trunks can be compressed between these muscles, or if there is an injury to these muscles. So now, trunk level. So the nerves has been compressed at the trunk level. So this patient, this is the trunk level in my plexus. And now the Schleny syndrome. Patient have, look, whenever nerve is involved, first thing is pain. Second thing is loss of sensation. Third thing is total, person will not feel anything. Some numbness, something is creeping. So these all are different manifestation of nerve involvement. So if the involvement is at the trunk level, who is responsible? The splenic muscle, because at that place it has been clasping around the trunk part of my plexus. So what we have to do, surgically probably we have to intervene and we have to do something, so that otherwise this is a severe type of pain. This is not simple, take one Panadol and you are fine. No, it's not happening. Third variant. And what is that? Costoclavicular syndrome. And what is in that? At the division level. You know where is the divisions. And now, what are the situations? What is happening due to this? So if there is a fracture, you know this is a small place. If there is a fracture of clavicle, below is the first rib. There is a very narrow space. After fracture, when the bone will heal, there is a callus formation. It might cause a compression. At what level? At the division level. So now in this situation, you have to do some intervention. Otherwise, this will be a severe, grave issue. Then, if at the cord level, one of the factor, hyperabduction. Where are the cords? Cords are here. Let's say there are certain people who sleep on their hand. They may get it. Or you are working in your home, the whole weekend you are painting the roof and all that. So hyperabduction. This is your abduction. This is hyperabduction. How long you can keep your hand in hyperabduction? If you keep it for hours, if you are painting the roof, think of it. After spending 6, 7, 8 hours, what will be the picture? So this is short term, but primarily you are compressing where? You are compressing at the cords level. So we talked about injuries at the beginning of the plexus, upper plexus, lower plexus. Then we took one by one at the root level. Then we talk about trunk level. Then we talk about division level. Then we talk about cord level. So these are the injuries which are occurring to what? To the brachial plexus only. Now, the injuries to the individual nerves, that we will be learning. When we'll be doing them. If I teach you today, you don't know much of it. It's a waste of time. Long thoracic nerve, you knew it. If injury to long thoracic nerve, you'll have winging of scapulae. But others, probably you're not good with that. So we'll be dealing with them shortly when they will be coming on the way. There is no hurry for that. Okay, so now these are different situations. I don't know you know it or don't know it, just to show you. Because the idea is you should be familiarized with that. If your brain knows, you will learn it next time. So this picture, this is a simple test. So you can try. So this one you can know. This is an injury to the plexus. You can see that weighted tip hand or abductional thing. What about this? This is a median nerve injury. Ulnar nerve injury. This is a radial nerve injury. Thank you very much. Now I am open for your questions. If there is any burning point, gentlemen, can you read for me if there is? But I don't want to say what is the spelling of triceps. I'm not interested in that. Guys who are sitting here, any question? Paul must be waiting on the other side. He is coming for his. Any question? Yes.
In the last presentation, you have a note box and you wrote in it that the trapezius and the levator scapulae, they are not from the brachial plexus. While here in the scaphoid, you have.
Okay. Listen. Trapezius supplied by cranial nerves. So it has to do nothing with the brachial plexus. Now I have shown you C5. If you go into the detail of C5, this C5 is not primarily from this part, it is basically having contribution from C4. That's why this is more advanced thing. If you're really targeting A+, then get into this discussion. Otherwise, simply remember that these two nerves, these two muscles, they are not directly supplied by the brachial plexus, that is through someone else. So that is the dorsal scapular nerve you're talking about. And the trapezius is a cranial nerve who's supplying it. It's not under the control of any of my spinal nerve. Are we clear? The 11th cranial nerve has a cranial part, accessory part, and the spinal part, but that's a different story. I'm sure you'll be learning it when you will be, inshallah, in year 2. I don't have time for that. We can talk outside because is it related to this discussion? You say it quickly.
Okay. Doctor, the Arabs mentioned
Duchenne palsy.
okay, it's from the upper roots.
Yeah.
And you said it involves C5, C6, and C7.
Yeah.
Why the long thoracic is not affected?
Because it depends on long thoracic was given before, just at the emergence, and this injury is occurring after that.
But the long thoracic is written in
is written, but that is given just at the beginning, and this is little after. And remember, what I said is not word from everything. It depends on if injury is involving the place from long thoracic is coming, you also have linking of scapula as well. So it depends on, but primarily when this injury occurs, because the long thoracic emerged just at the root level, so it's not happening, and this injury is little after. Anything else?
Are injuries to upper and lower parts of the plexus the same as superior, middle, and inferior in the truncal bone?
I didn't get your point. I think you need to read it. You need to go through this material and then you can rephrase your question after.
Okay, one of the slides says that the clavicle nerves are 7 and the other says it's 8. Which one is true?
What?
One
Clavicle?
of the slides says that the clavicle nerves are 7.
Huh?
Cervical.
Cervical. Yeah, basically there are 8. Ayman has spent good time on telling you one is coming above, and if you refer back to his discussion, he explained that there are 7 vertebrae, but there are 8 nerves. Ayman has spent good time on this concept. Okay, guys, I think it's time for Paul. So, all yours.
So what you have to do, you have to disconnect.
Thank you, doctor. I just wanted to ask, are you?
I will do that.
You'll
Don't
go
worry.
to that.
Don't worry.
Is the computer on?